Set a bit of a landscape for you. Persistent pain, as you will probably all agree, is a very urgent situation. 1 in 5 Australians will suffer chronic pain in their lifetime. It's likely to increase. It is rising also in 1 in 3 Australians, which basically tops it on the list at the moment. If you're 1 in 3, you're kind of making it on the top 1 or 2, 3 chart. And musculoskeletal conditions and chronic pain, they're separately categorised, but they are the top 2. So you could very well say that really it's the second greatest national healthcare burden. Unfortunately, when I started the work, it was actually the National Pain Strategy. If you could read a document that didn't put you to sleep, I assure you that is one. I was grabbed from the minute I read the little foreword that was written by Professor Michael Cousins. It was very inspiring, and it actually propelled a lot of my work. Just from that document, I must say, it's either you could conclude that I don't have a life, or that it really is an inspiring document. Very simple to understand, and what was alarming was it was the first time, I went into the game thinking that I was all behind, but I realised in 2010 that we only just began. So as a country, and many countries around the 2009-10 year, kind of got together and started to have a national, their own strategy. So 120 pain specialists and pain interested professionals came together at a summit to agree on 5 goals for the country in pain. Unfortunately, statistics that were born, such as 80% of people with living chronic pain are missing out on treatment, was the type of statistics they were getting in that annual report presented in 2012. So it was kind of exciting in a way for me too to think that, wow, there's so much we can do. We're still at the infancy of it, although we have certainly progressed. Some of the other statistics which are really quite alarming: 1 in 5 chronic pain will suffer depression or mood disorders. There's 21% suicides in Australia. There's probably more unreported. The risk of suicide is twice as high in people who have chronic pain. Currently, right now, I've got 2 fairly high-risk cases verging on that. So obviously we have to reach out to our allied health partners for that. This is very interesting as to what you and I are paying. In the labour force, there was in 2003, the most common chronic pain conditions that we're managing is back pain and arthritis. They are not conditions that live in a hospital. You'll agree that they're common conditions that live within the community, and they are where the derail can happen a lot of the times when they're not early intervened, when health literacy is poor. If those patients stop to work around the 45 to 64-year-old age group, so your disability pensions, and if they only earn an income less of a quarter of what is an average income, what will happen is that basically it's forced retirement. It'll cost us a whole heap of cash, and unfortunately it's poverty for these persons. So when we say outcomes are important, our outcomes is not just about being pain-free or pain, intensity reduction. Our outcomes is very much about trying to stimulate some return to some engagement in the working field as well. No matter how small, whether it's voluntary-based as a beginning or building up from there. So that is very important within our program. The other interesting thing was you never think about morbid presenteeism. I really like the word. You're present, but you're not. So for a forklift driver, for a bus driver, you might be not feeling that great, holding some high-risk jobs, and you're there, but you're not. And that's what they call morbid presenteeism, which I think is I kind of wanted to allude to that because I thought it was a pretty cool word. But we never think of that whole, pain experience while performing at work and underperforming as a result or at risk. So that's also a very real thing. A couple of other quick stats which I think are important. Less than 10% of people with chronic pain gain access to less than one effective care when it's all, the spits and spurts, and bring that all together, it actually equates to less than one effective care. 80% of people could be treated if there were sufficient access to pain services. There is definitely still a lack of resource there. Unfortunately, most pain services are greater than 12 months wait list, usually, and there's about 40 centres only in Australia. And unfortunately, actually my current work goes between regional and Gold Coast based, so I see the regional needs a lot. Between rural, regional, remote, Indigenous communities as well. Interestingly, different cultures interpret pain differently as well, so the needs are again different. I had to understand my own Asian culture of how they interpreted pain and how they understood pain and how they suffered till they say something only when they're at severe suffering, which is very interesting when you then look at the science. I want to just share with you before we get too clinical about how collaborating works in terms of our program. I am going to start with just looking at how our pathway works and just building a bit from there, so you kind of get an understanding of how primary health, this program has been designed to incorporate primary health. So our whole idea for the program was to collaborate with Allied Health and the team, creating mobile MDT type systems for better health access, because if we have better health access, the health economics tends to improve. So the 6 keys was improving health literacy in understanding persistent pain. That is significant, because without getting why you would want to treat it like a chronic condition, you don't engage very well with treatment. Improving self-management skills is also important, because living despite pain, having a quality of life despite some pain, is critical. Improving primary healthcare service utilisation. Like I said, there's a lot of good rich resource. We've had to go out and hunt them out, and to really try and stimulate that within the community and see who is there. There's actually a lot of good resource. It was a matter of finding those people and explaining how they will work within a collaboration pathway. Group education, and I'm not sure whether you guys do group education here or not, or have that experience, but I'm sure there'd be parts of it that you do. We find, and the statistics certainly shows, that the group education model works extremely well. The statistics on outcomes improvement, there's something special in groups, and we call it our group neurons. Our group neurons get switched on. It's that whole camaraderie, it's that whole belonging. Removing isolation simply does everything, apart from the psychosocial needs, but it also improves sleep, will you believe it? So our sleep specialists are very pro-group education, so part of our resources is spent doing that. The other thing is we do provide individualised care, so very flexible. Not everybody's appropriate for group, so we also have the individualised case management, case planning, case navigation. We will and do work very nicely with the hospital departments. We do have currently on the Gold Coast the interdisciplinary persistent pain centre, they're called, at the Gold Coast University Hospital. It is Robina based. They were under a fair bit of load because of resources, but they're a wonderful partner. We've had to build those relationships, but we do inter-refer. A lot of their waitlist situation was Category 2 and 3 patients whom they weren't really honestly going to see very much of, because the resource of the pain specialist was very much in a Category 1 field. So Cat 1 is where there is an urgent need for intervention. The rest of the burden of, you think of the back pain and arthritis, not many of them really, as an ongoing chronic care management, would need intervention, and if that, or ongoing intervention, and if that, sometimes the intervention will fail them in their care. So we've partnered up very nicely with ER and orthopedics and neuro, and that's been a 3-year making friends type of exercise, and it's been a matter of just literally getting in there and making friends and getting each other's support on that. I'm going to show you roughly the pathway in sort of nice pictures. The GP generally, when I say GP actually, now it's more any clinician, identifies a patient who needs persistent pain. The numbers there are really merely just for the doctors really, their claim numbers and stimulating them to know how to use the MBS system. But what happens is once they refer in, it's triaged at our end. And there's a phone call, there's an introductory service, just for us to understand that they're definitely meeting the eligibility criteria. Then the patient is certainly streamed into their expert education forums. So they get almost like a workshop list of when the next one is on, and they're registered into that automatically. Now, from that process as well, we will see them individually to then plan their care, which is on this other side. And this is when the MDT system starts. We don't overwhelm them, so we have to be very careful about how excited we get in terms of offering this, that and the other, because it's not about what we think is important, it's about what our patient thinks it's priority to them as well. We've had situations where, you know, patients have needed housing and we've actually had to not start treatment till some of their very basic needs were sorted. So it was obviously off to some other organisations, Auschcare, MICU, even community housing, to assist us before they could come back in. There is no order to this. However, what we tend to do to make sure our resources are well utilised is we use what's available on the Medicare system first, and then we top up the funding from our brokerage funding on the rest. So that then this is what we call a mixed funding model then. Because every patient is allowed actually quite a bit on Medicare, but they sometimes don't know how to access it. So, for example, they can have a visit from a consultant pharmacist. Now, we have recruited consultant pharmacists who work alongside us, who are skilled specifically in other things, but including pain. So we've been quite particular about making sure that each individual of our allied health kind of get the consistency of the same messaging. That has been critical. Similarly, psychologists. So we've got a network of psychologists around the coast. Now, patients tend to want to go to where their people are. Even on the Gold Coast, it's not so far between north and south, but nobody wants to cross that midline or that border. Especially when you start to get to Tweed, you know, that border is really, we don't cross that. So it's really important to localise care when you're thinking about primary health care partnerships as well. So more friends to make, consequently. So the psychologists, obviously we use some of their mental health services available to them. It's actually quite generous. So the government does get 10 services to the patient. And you know, remembering that they're also coming to group education and remembering that everything's consistent. So the utilisation of the resources on this side with the allied health is very efficient, consequently. The handover's quite smooth, usually. Then we bring on, obviously, our physios and ex-phys and OTs and dietetics, all the as they need. Not everybody needs everyone, but as they need. Now, we do have, like I said, brokerage funding, so we then top up what then the patients need within that 12-month period. The whole idea is if we dissolve, if things, remember the word sustainability, if this falls to a part and we go, which we will eventually because, 12 months engagement, the patient is self-managed and we're outcomes driven, so we have to get them to that point. They have their team. Their team is based locally in their environment. So then if they have their team, then they don't keep bouncing urgently. I'm sure they will have instances where they need to, but they don't bounce urgently into the public space all the time. Any questions on that? That's kind of roughly the pathway we've created. It's actually a bit of a no-brainer, actually. There's no magic in it except for just lots of good organisation, lots of good consistency. There are some really ground rules in primary healthcare modelling, and a lot of time is actually spent in communication, the age-old communication amongst everyone, and being very fluid about that. Certainly what is kind of nice, this is the only model that provides some extra funding for patients to get the allied health care. I mean, allied health are critical in this space because it's about a multimodal type of care rather than any one isolated thing. We operate on two forms. That is all. We don't do huge, 2 forms, meaning 2 referral forms. Of course, we've got our own clinical documentation, but it's to try and streamline and simplify. Okay, so just to give you a quick look, what does the patient really get? They get a 6-month pain education program, which we've named Turning Pain into Gain. They meet others, they make friends, they improve their health literacy, they become basically better self-managers. It's a 2-hour time slot only, so it's what we at each month. So it's what we call, there are different, when we talk pain programs come in different intensities. There's no comparative, there's a rough guidelines about how many hours makes a program, but it's anywhere from, 8 to 20 as a very broad guide. In our case, we find that our expert presenters come in through a range of different topics, very holistic. Monthly for 2 hours is all the patients will attend for, and then they've got all their other MDT stuff to do as well, and their health case meetings with us. So they get all kinds of things, full program workbook, even a loyalty card, morning tea. So it's very, it doesn't look too clinical, but they are certainly getting lots of good clinical information. We've expanded to host in community centres just to be with the people. So Robina, Southport, Coolangatta, we did Coolangatta this year. And then our funding does allow us to also have refresher programs. So patients from our 213 cohort can come and do 1-day top-ups as well for refresher programs. We do also have a walking group at the Botanical Gardens, which our nurse counsellor runs, and that's a very mindful type of beautiful, in the beautiful sensory garden. So we also try and apply that. Hotline support, email support, all the usual stuff there. We also, actually, what's been amazing is we've had 2% of our patient cohort. UK has a program that's an expert patient program where the patients kind of become, well, not really the clinical facilitators, of course, but they do share in being part of the facilitation. So we have 2% of our, the UK run on a 1% outcome. We actually managed to get 2% of our patients to become the expert patients. So they've gone on ahead and they're just so awesome. They've started their own patient support group, and they come and support us at the actual clinical program also. So it's all, these little things do matter in building a primary healthcare initiative program. Now, here's just a couple of pictures about, obviously, our interdisciplinary care approach and how we all reinforce knowledge, the learning, keeping it consistent, that's critical. And we've got the funding for extra services. That's a physio up the top. Ruth, the nurse counsellor, she's mindfulness trained, and she's EFT trained. So certainly we don't replace a psychologist. We might introduce the person into being comfortable to then be handed over to a community-based psychologist. And we are on board for 12 months with them.